Okay, so we're going to jump in and end the day with a little bit of positive parenting and promoting mental health. So these slides were adapted from Kate Perkins, who gave this talk before. I will try to do them justice. So just as a quick poll, how many people here are parents? Excellent. So you can relate to a lot of these issues probably. So part of the reason why we wanted to include this was because mental health is really a really critical part of the Bright Futures guidelines. And in fact, Bright Futures has this statement that establishing mental health and emotional well-being is arguably the core task for the developing child and for those who care for the child. And so, this is not just an afterthought, but rather a core part of child development. So mental health promotion requires really these 4 steps, which is the steps that we apply to pretty much all health promotion, right? Risk assessment, prevention, diagnosis, and treatment. And we're going to talk a lot about risk assessment and prevention as part of this talk because in many ways, for those of you sort of on the front lines of pediatrics, this is a huge part of what you're doing. So on the prevention side, a lot of what we do is teach parents about what normal development is, right? So they know what to expect and can anticipate and put into context what their child is doing. We also want to sort of anticipate these critical developmental periods where the relationship between parent and child might be challenged or strained, and where that mental health of either the child or the parent or both may be compromised. So we want to be able to help families anticipate those periods and sort of strengthen them and give them the tools they need to weather those storms successfully. So we're going to talk about some common behavioral concerns, sleep being a huge one, toilet training is another sort of challenging moment. We're going to talk about discipline and some strategies for discipline, and then we're going to talk about screen time. And I don't know if we'll have time to sort of get into toddlerhood, so we might have to put that one on the back burner. Okay, so sleep. I will say this is probably like the number one thing parents are concerned about, right? And it's really, really common for parents to have concerns about how their child is sleeping. So if you look sort of in a general population, about a quarter of healthy children, their parents will report that they have a sleep problem in kids under 5. So that's a huge population. And then if you look at children with special health care needs, so kids with a developmental delay or other chronic diseases, that can be up to 80% who have sleep problems or sleep disorders by parental report. And it's often like the first thing that you hear about from parents, right? The very first concern they have is often that their baby wants to be up at night and sleep during the day, right? So day-night reversal is this sort of classic thing that comes up, usually around 2 weeks of age, and it's more common than not that babies sort of have their days and nights reversed, so most babies would prefer to be up and hanging out at night and then snoozing all day. The treatment for this is actually phototherapy. It's exposure to light during the day. So not the same phototherapy we do for high bilirubin levels, but phototherapy nonetheless. So at night, you keep the lights down low, you keep handling and playtime to a minimum. Nighttime is for sleeping. And then during the day, even when the child is asleep, you keep the shades open, you talk in normal voices, the lights are bright, and you try to sort of interact and stimulate the child during the day. And eventually, the good news is, eventually, the kids sort of catch on that this is what we do, we sleep at night, and we play during the day. So next I'm going to talk a little bit about normal sleep physiology. So we know that actually in a fetus, they can detect that at 28 weeks, a fetus will have REM sleep, so that's that active sleep, rapid eye movement sleep. And they don't really develop that non-REM sleep or that quiet sleep until about 32 weeks gestation. And when babies are first born, when they're term babies, they actually have sleep onset. So when they fall asleep into REM sleep, that active sleep. And what we'll see is that by 4 months of age, this slowly develops into more of a typical sleep pattern that we have as adults. So at 4 months of age, they start to fall asleep through non-REM sleep, and they start to develop these cycles, which is what we do when we sleep. You fall in during non-REM sleep, and then you kind of pass through REM sleep, and then you have this stage of arousal, and then you fall back into deep sleep. And so we all do this all night long. We go through these cycles. And at 4 months of age, that's the first time that babies develop those same cycles. And that's really important because when we get to sort of sleep training, you'll see that that cycling is really critical. So most adult sleep cycles, we kind of cycle through every few hours. By 3 years, the kids have the same sort of duration of their sleep cycle. So at 4 months, they first develop that cycle, but they're cycling through much more quickly than we do. By 3 years, they start to develop more of an adult duration of the cycle. And then that's what they have sort of through the rest of their development. So that sort of explains the typical nighttime waking patterns by age. So when babies are first born, we don't expect them to sleep through the night, right? We expect them to be up every couple hours to eat. And so parents don't complain about sleep problems then because they also expect that their babies are up every couple hours. By 4 months, again, when those sleep cycles first develop, babies are capable of sleeping through the night. That doesn't mean that they will sleep through the night, but they are capable of it. They do, however, have this arousal every 3 to 4 hours, right? They cycle through and they come back into that light sleep, and they either fully arouse or partially arouse. And then, something's got to get them back to cycle through that deep sleep again. And we'll talk about what that can be. By 6 months, we expect that babies should be able to self-settle, meaning once they come into that light sleep and that arousal, they should be able to get themselves back into the cycle. And if they can't self-settle and go back into that cycle, then we call it a sleep onset association disorder. So at that point, it's sort of in the abnormal bin. And you can sort of reassure parents too, we all do this as well. We all kind of cycle into that light sleep, and we may arouse partially or fully, but we all settle ourselves back to sleep. And part of what we do is, we use sort of the sounds and the smells of our sleep environment to help give us those cues, those reassuring cues, and get us back into sleep. Okay, so we'll talk about the sleep onset association disorder. Again, nighttime wakening before 6 months can be normal, but after 6 months, what you're seeing for babies who really are not settling themselves back into that sleep cycle is a conditioned response. So something gets that baby into their sleep cycle. And in some cases, it might be, for example, a baby falling asleep at the breast. So if the baby needs the breast to get into their sleep cycle, and they come back into that kind of partially aroused or fully aroused state, then they need the breast to get back into their sleep cycle, right? So these are the moms who come in and say, my kid wakes up every 3 hours like clockwork. I go to them and I think they're hungry. I put them to the breast, but they don't actually eat. They just take a few, sucks, and then they go right back to sleep. I don't know what's going on. They're not hungry. Well, that baby's conditioned, right? They know what they need to sort of settle and soothe is the breast. And this can be lots of things. Sometimes it's the bottle, sometimes it's the breast, sometimes it's rocking. It depends on sort of what that child is conditioned to need to go back to sleep. So the treatment is basically breaking that association. The child has to learn how to go to sleep without parental assistance. So you can sort of set the stage for success by making sure that parents place their babies in their bed drowsy but awake, so that when the babies first go to sleep, they learn to do that on their own without this other assistance. And then when they wake up in the middle of the night, they're sort of taught that they're expected to do that again, put themselves to sleep without help. So many people will notice this method as sort of the cry it out method, what's written here, right? There are lots of different strategies for doing the cry it out method. Some people say that you should go back at progressively longer intervals. So like in the middle of the night, the baby cries, you wait 1 minute, go in, put a hand on the baby, reassure them, and then leave. And then the next, you wait for 2 minutes, you go back, and 3 minutes, and so you're sort of like progressively going longer. Other people say, you just wait 10 minutes off the bat. Some people say, you can even, as long if you have like a monitor, a video monitor, you don't necessarily have to go back in at all. So there's all these different strategies for how to do this. There's not a lot of evidence about which strategies work better than others, but I will say sometimes family temperament can help drive that. Some families are sort of more comfortable with this than others. And, the good news is that most babies will learn to sleep on their own if you do this over the course of a week. It's not a fun week, but they will get there. Right? And it's also sort of helpful to tell parents that sometimes the second night is worse than the first, because babies will sort of escalate it. They'll take it to the next level to see if that will get you to come in and, give them the breast and the bottle or the rocking again. But they will survive. They will get through it, and it takes about a week. Questions about sleep training? Okay. The next time that kids start waking up again in the middle of the night is something that Bergen alluded to. So this tends to happen between 8 and 10 months, and it's again sort of that like magic 9-month-old period. This is babies who were sleeping through the night just fine, and then all of a sudden are like, Bergen said, kind of standing up in their crib and crying in the middle of the night. So we think that this is because of sort of 3 developmental processes that sort of happen at the same time. One is that increased mobility, being able to pull to stand. Sometimes they might get stuck up there. Sometimes they might just be up in the middle of the night practicing their skills. The other is stranger anxiety. So they know that not seeing familiar faces is kind of anxiety provoking, and they get scared or distressed when they don't have familiar faces around them. And then the third is that object permanence. So they know they're alone. They know they want to see a familiar face. They know that that familiar face, mom or dad, is next door, and they're not right there with them, and so they're screaming and crying, trying to get them in the room with them. So you can reassure parents again for this. This will pass. It's a developmental phase, and their baby will once again sleep through the night. Okay, the next phase happens in older children, so more like the preschool age children, sleep refusal. So there are a couple different causes of sleep refusal. One might be bedtime fears, and the other might be inadequate limit setting. And so we'll sort of talk through how you can tease these out and what might be the causes. So limit setting, you can usually tell this because these are kids who take a really long time to sort of wind down and go to bed. So these are the kids who want one more drink of water, one more story, right? Like they're just like drawing it out. A bedtime routine should last 30 minutes or less. If that bedtime routine is taken an hour, it's probably sleep refusal. So the treatment is really establishing a consistent bedtime and a consistent routine so that kids can sort of anticipate when sleep is coming. You want to eliminate late naps just so you sort of set the stage for success and their child is actually tired. And then set firm limits on curtain calls. So that's that, no, I'm sorry, that is the last drink of water. You may not get out of bed again. And then rewarding successes, which is a key part of discipline that we'll talk about later, is you really want to recognize positive behavior. For example, if you stay in bed without calling out, you'll get an extra story tomorrow night. Now, bedtime fears can sometimes look like this, but usually it's something that you can usually elicit from the history that this was triggered by something. The kid saw a scary movie, or they were separated from their parents, or something scary happened to them, and they're sort of fixated on it. So really the treatment for this is acknowledging the fear and reassuring that child. And to the extent possible, you want to help the child regain a sense of control over their environment. So sometimes we talk about, for example, fear of the dark. This is a child who you could give them a flashlight, and then they, not only is the dark gone, but they have control over creating that light. So that can be very reassuring to children. And sometimes if it's really a significant fear, sometimes a parent may need to stay nearby as a child falls asleep for a brief period of time to reassure them. Okay, night terrors. How many of you guys have dealt with night terrors? You guys know what night terrors are? So we're going to talk about night terrors versus nightmares. Most of us know nightmares, right? We have them, our kids have had them. Night terrors are slightly different. So these tend to be in slightly younger children. And the child may be really distressed, may pop up in bed, be screaming. They may look kind of pale and sweaty. Their pupils might be dilated, which, maybe in the middle of the night you might not notice because hopefully the lights are down. But the thing about night terrors is kids are not actually fully awake, and so they can't be comforted. They're not actually aware of you being there and trying to comfort them. So this can be very distressing to parents because their child is really upset and they can't calm them down. It can be triggered by illness, stress, or even if a child is a little bit sleep deprived. And just to sort of reinforce the difference, because children are not actually awake for a night terror, they have no memory of the event. The next morning, they're not scared, they don't remember it, they don't know that you were up at 2 in the morning in their room. It's not a dream that they're having. The stage of sleep is different, actually. So a nightmare happens in REM sleep, a night terror happens in non-REM sleep. And the timing tends to be different, where night terrors happen earlier in the night, nightmares tend to happen later in the night. They could have a positive family history. Again, they're not comforted by their parents being there. And they tend to happen in slightly younger children, although there's a fair amount of overlap here. So the treatment for night terrors, again, is really parental reassurance. It's much more distressing to parents. Children are not bothered by this at all. Most will resolve by kind of mid-school age. It can help to sort of empty the bladder before bedtime and keep the environment dark. Some people say that you can sort of break this cycle. Again, you can sort of reset their sleep cycle by waking them up about 45 minutes after they fall asleep. But again, it's really more distressing to parents than the children, so you really don't have to do any treatment. The books and sort of articles say that you could use benzodiazepines, but we definitely would not advocate for that on a regular basis. Okay, any questions about sleep before we move on to toileting? Okay. So toilet training. I had one of my mentors told me that toilet training is sort of your practice for adolescence, that as a parent you should sort of reflect back on how toilet training went, and that is how the adolescent years will go for you. So that's always good to keep in mind. So for toilet training, there's really a couple things that kids have to be able to do. They have to cognitively understand that they are supposed to pee and poop in the toilet, and sort of respond to their social norms around that. And then they have to have the neurologic capacity to follow through with that. So they have to recognize their bowel and bladder signs that they're full and they need to go. And all of that happens around age 2. But in our culture, in the US, the average age for being toilet trained is about 30 months, and we'll kind of get into this a little bit more, but in other countries, people toilet train much earlier. And we have access to sort of easy access to disposable diapers. It's very easy to keep a child in diapers longer. And so, that may be some of the reason why there's these social differences. So many people will start talking about toilet training at the 18-month visit, but I will say depending on your patient population and what their sort of social norms are, you may need to start having this conversation much earlier. I have families who toilet train at 15 months. So if I waited to the 18-month visit, I would have totally missed the boat on that. And the reason why we talk about sort of the 18 to 2-year time frame is because that's when kind of final successful toilet training is most likely to happen. So what you can start doing really early, though, is talk about signs of readiness. So parents should notice if their child is dry for more than 2 hours. That suggests that they actually have sort of control over their bowel and bladder. And then they have to know the difference between wet and dry. Their child has to know the difference. Their child has to be able to pull their pants down. You don't have to get them up again on your own, but you got to get them down. And they have to show interest. The other thing is they have to be able to communicate that they need to void before it happens. So usually kids will first communicate that they're wet, and then they might communicate while they're going to the bathroom, and then eventually they'll work it back to be able to communicate before they have to go. There are a number of different techniques. The main take-home point here is to keep it really positive and just follow the child, let the child sort of be your guide. Sometimes it may help to have demonstration by a same-gender parent or sibling, and so if that's not a member of the household, you may need to recruit somebody to actually show the child how you go to the bathroom. And again, you just praise any sort of positive movement in that direction. Sometimes that means just sitting on the potty with your clothes on gets a lot of praise, and really sell it as a desirable thing. Other little tips to help is taking the stool from the diaper and putting it in the toilet so kids start to realize that's where the poop goes. And then for aiming, I don't know if any of you have had boys, but for aiming purposes, floating a Cheerio in the toilet can be a great target. So the other thing that we really want to do is anticipate things that could go wrong and could be challenges. So you really want to explore parents' thoughts and concerns, and even pressures that they're getting from family members, and external pressures. The classic one is a kid who has to be potty trained to get into daycare. So one thing that we can do is help parents realize that putting that extra stress on their child is probably not going to help potty training go well, right? So they really need to be aware that the more stress there is associated with this, the worse it's going to go. Again, the average age in the US for successful training is 30 months. And some of this has to do with the physical capability. Our nervous system sort of develops again from head down to sort of the bottom of our body. And so we don't actually finish myelinating the nerves that send messages from our bladder to our brain until around age 2. So that's why it's harder for kids to successfully potty train before then. Most kids are dry during the day, before nighttime, and actually primary nocturnal enuresis, which is bedwetting, is very common and typically self-resolves by age 7. So it doesn't require any intervention or workup if it's before age 7. Again, avoid battles, celebrate success, keep it really positive. And then the other note when we're thinking about sort of preparing our families for potty training is really to watch out for constipation and to treat it pretty aggressively, because a child who's constipated at that age, things can often sort of escalate and you can get into real problems there. So you do want to sort of counsel on that. Questions about potty training, toilet training? Okay. So discipline. So there are a few sort of core principles about effective discipline, and probably the most important one is reinforcing positive behavior. So when we think about discipline, we're really thinking about conditioning our children, right? We want to encourage the behaviors we like and discourage the behaviors we don't like. So probably the best way to encourage a child is by giving them attention. A parent's attention is one of the most valuable things to a child and the most meaningful. So you want to catch your child's good behavior. And we use the word catch because it doesn't matter what motivated that good behavior. They could have done it by accident. They could have done it reluctantly. But if it's a behavior you like, that's what you want to reinforce, right? Not the motivation, but the behavior itself. And then reward that behavior with lots of praise and attention. So I like how you shared your toy with your sister. Let's go read a story together. Heap on that attention. You want to set up and enforce limits. So avoid ultimatums by setting limits and then following through with them. So you'll notice in this example here, Josh, put away your toys or you can't help bake cookies today. you'll notice that this is phrased in the behavior that you want to see. Put away your toys, not don't leave your room dirty, right? It's the positive behavior that you want to see, and it's very specific. And then there's sort of a natural consequence that's desirable to the kid. The kid wants to bake cookies, so, put away your toys or you can't bake cookies. And then when you give commands, we talk about CCQ or CCCQ commands. So that stands for clear, calm, close, quiet. And I will say, every time I actually, in the context of my day, remember to give a CCCQ command, I'm amazed at how effective it is. And I think man, why don't I do this all the time? Because typically what I do is yell at my children while I'm washing dishes, hey, Isaac, stop it, totally not effective, as opposed to coming over closely, getting down to eye level and saying, Isaac, put your shoes on, right? That's very different. And it's much more effective. So when things go wrong, you want to talk about it. You want to explain why the behavior was inappropriate, and you can actually engage the child. The child can sort of help you troubleshoot how things could go better the next time. And one strategy here is actually you can kind of do do-overs. You can reenact doing it better, and you can also tell stories about, Isaac, yesterday Isaac was hitting when he didn't get what he wanted, but today Isaac says, I want that, Mommy, so that can sort of help make a concrete example for kids. And then kids are constantly watching you, right? So just being a good role model goes a long way. And when you do something wrong, it can be really instructive to actually apologize and, admit when you make a mistake. And the last, most challenging thing is being consistent. So if you say that there's going to be a consequence, right? If Josh shouldn't put away his toys and he can't bake cookies, you really have to stick to it. So that being said, probably the greatest struggle in parenting is knowing when to sort of stick to those really kind of firm rules and when to sort of allow that wiggle room. And I know that's what keeps us all up at night, is thinking about those choices. So here are some common discipline strategies according to age range. So just like positive attention for good behaviors is very effective, active ignoring is an incredibly powerful strategy. So that's really withdrawing attention for behaviors that are undesirable. And that usually, it's helpful to coach parents that usually what that results in is first a child sort of escalating behavior because they really want your attention. And if they're operating on 5, that's not getting your attention, so they're going to amp it up to 7 and then 10. But eventually you see that behavior extinguish or go away. In young children, redirecting and distracting them can be really effective. So if they're really focused on wanting to, play with something that, what your phone or your tablet, and you want to get them engaged in something else, really distracting them and getting them involved in alternative activities, very effective. In children older than 3, a timeout can also be effective. You can use that in younger children as well, but this is the age range where it's probably kind of one of your go-to strategies. To use a timeout effectively, it is really when a child has broken a specific rule and you've set up sort of the rule ahead of time. So the child knows that this is a rule, they have broken it, and you've told them that they will get a timeout. You also want to choose a timeout spot ahead of time. A timeout spot in their room with all their toys is probably not going to be super effective because they're going to have a blast, right? And that's not what you want. So you want to choose an area that's boring. Sometimes it helps if it's an area where you can see them. And then you set a time limit. So the typical recommendation is 1 minute for every year the child is old. So if a child is 3 years old, their timeout would be for 3 minutes, right? And when you put them in timeout, you sort of explain that. You're in timeout, you are to sit here for 3 minutes. It helps to use a timer. And then once the child is out of timeout, you just resume activities as normal. They've paid their dues, and now it's sort of a fresh start. And I will say, the point of timeout is really social isolation and removing them from something pleasurable. And you can use that same technique even in younger children. Sometimes a timeout for a child that is, a young child that's misbehaving and wants your attention is as easy as kind of putting them down and turning your back on them. It does the same thing effectively. And then for all children, you can withhold privileges. So choosing something that the child values, but one thing that we never want to do is take away something that a child truly needs. So you don't want to take away a meal or have them not be able to use their jacket on a cold day, not anything that's important for their health. Okay, so challenging behaviors. When a child is exhibiting sort of a negative behavior, something that you don't want to see, especially for young children, it can actually help for you to coach them in a role play. So you can use like a doll or a stuffed animal to do this. Again, you can sort of tell stories about how a child's behaving, and it helps them sort of work out and plan their own response. You can also model like what happens when a child doesn't play nicely versus when a child does play nicely, and make it really concrete for young children. Again, setting expectations, catching them being good, reminding them of the good behaviors that you want to see. I remember one parenting instructor was supervising a field trip of like upper elementary school kids, and they were sort of running down the hall, and all she did was stand at the door and say, "Walk, please, walk, please, walk, please," and everybody running by her, just suddenly stopped and started walking. Just reminding them of the behavior that you want to see actually does affect their behaviors. Sticking to your word and having clear consequences and sort of rules laid out ahead of time is helpful. And then natural consequences for bad behaviors is probably the most helpful way of implementing those. Behavior charts can be helpful, so those are most useful when they're very clear. The behaviors that you want to see are laid out clearly, and then a child might get a sticker for every day they do that, and then that helps you see over time, like, wow, this whole week you did such a great job of getting dressed on your own or leaving the house without whining. And then that usually deserves some praise or a prize or something. And then, if things are escalating and they're getting more difficult to manage on your own, that's when you really seek help from a therapist or interventionist. So just to take a moment about spanking, this is still a pretty common disciplinary strategy, and just to be very clear, the American Academy of Pediatrics strongly opposes striking a child for any reason. If spanking is spontaneous, parents are supposed to explain calmly why they did it, and the behavior that provoked it and how angry they felt, and they may apologize to their child for the loss of control. And this is, again, getting back to sort of that good role modeling when sometimes we do things that, we wish we hadn't. This usually helps the child understand and accept the spanking, and, again, models how to remediate a wrong. So why the AAP opposes spanking is because although spanking may seem to help in the short run, it often can actually make matters worse. It gets the child's attention, but it doesn't necessarily explain to the child what they did wrong and what behavior you would like to see. Our children are watching us, and so we don't want to role model violence as a way to solve problems or to communicate messages. And instead, there are many other techniques that are much more effective, including like redirecting behavior, teaching children why their behavior is wrong, and also getting them to think about the feelings of others, really understanding how their actions impact others. Questions about parenting, discipline, spanking? Okay. So the last topic is really about media. You all may know that the American Academy of Pediatrics recommends no screen time before age 2. And this can be really hard to implement. This is because exposure to screens have been associated with attention and focusing problems later on, and so for developmental reasons, it's recommended to avoid. After age 2, the recommendation is to limit media time to less than 2 hours a day, which is also really challenging because it's so pervasive in our lives. And then in addition to the quantity of media that our children are exposed to, really the quality is very important, as well as adult supervision. So, if you think about the variety of screens that are in our households and in our lives, this includes TV, computers, video games, cell phones, tablets, any sort of media. You want that media to be used in a place that is easy to supervise. So it should be in full view of adults and other people in the home. So the worst thing is to have a TV in a child's bedroom or a computer in a child's bedroom where they can be using it unsupervised. You want it in sort of a high traffic area. General rule for TV is to watch programs with your children so that you can both help talk through kind of what they're seeing as well as monitor. Computers should be used for schoolwork or educational purposes, and then have that sort of less than 2 hours per day limit for non-educational use. And again, there's lots of things you can do to sort of monitor what kids are doing online, and even putting timers on iPads so that you can limit that time use. Many things, including TV shows, video games, have a rating system, so parents can use those rating systems to help them choose what programs would be appropriate for children. But again, the very best rule of thumb is that they should be supervising and watching or using that media with their child, both so they can have a good awareness of what their child is doing, and then also so they can help that child process what they're seeing. Questions about media? Okay, I think that's it. So then just to wrap up, we talked about some common behavioral concerns, and this slide is really just to emphasize that some of this sounds really easy, but it can be really complex, and especially when you have a family in front of you who's working through a challenging time, there's a lot that you're trying to take into account. So for bedtime struggles, for example, you're thinking about the developmental and health status of the patient in front of you. What is that child's ability to self-soothe? Do they have a developmental delay? Are there other health concerns? Do they have a chronic health condition, asthma, that's keeping them up at night? What's that child's temperament like, and how does that match with their family and their parents? What's going on in the family dynamics? Is there a good bedtime routine? What is their family's approach to sleep? Their family's approach to having a transitional object. And then beyond just sort of the family social interactions, are there some environmental pressures, like have there been changes in the family, or are they doubling up in a home with another family where maybe the parents don't feel like they can let their child cry at night because they're staying with relatives or friends, and they're very sensitive to disrupting the sleep status in the family. So kind of across all of these areas, we want to think about all of these factors simultaneously and help families unpack them and address them one by one. And I think that's it. Questions about anything that we went over? All right, I think we're done for the day.